drug, venetoclax. And now that this is approved, more and more you'll face the situation how to transition a patient on CLL from ibrutinib to venetoclax. And as you are well aware, even if a patient with CLL progresses on ibrutinib, still the drug seems in many cases have to have some foot on the brake. And as you stop the drug, the disease can take off. Yet at the same time, when you want to start venetoclax, you cannot start full dose. You have to have this ramp-up scheme. So it takes a while until the drug is actually fully active. So if you could please comment on how in clinical practice you would transition a patient who's progressing on ibrutinib to venetoclax.
Really important, good question. I don't know if this is, can you hear me? Okay. If you can't hear me, wave at me. Doesn't seem like it's on, but I guess it's okay. All right, well, no one's waving at me. So this is a really important point that Dr. DeVos makes, and I think we don't know the answer to it, but that is, how do you transition from ibrutinib to venetoclax? And I would say my very short answer, and I'll give you a longer answer, but my very short answer is that what I'm really doing more and more is I'm not transitioning. I mean, I am transitioning, but I'm not stopping the ibrutinib. Actually, I keep it going. So why is that? Well, we know CLL is a very heterogeneous disease, and one of the things that we've learned is that if you develop a BTK mutation, as an example on ibrutinib, you're obviously losing control of that clone, but there are subclones that the ibrutinib is still actually keeping well in check. And one of the things prostate that we learned cancer is that in the very early studies in very aggressive, heavily pretreated patients, is that if you stop the ibrutinib, people would relapse very, very quickly. And the reason is because it's not just that clone that has the mutation, it's also all the other subclones that you're suppressing that you're taking the brakes off of when you stop the ibrutinib. So if you start failing ibrutinib, don't just stop it and switch to venetoclax. At least we don't have data on that, but that's probably makes sense, and a lot of people are starting to do this. So phase in the venetoclax while you continue the ibrutinib. Again, the ibrutinib is controlling those subclones that are still very important. And then once you're on the venetoclax, you can make a decision if you want to continue both drugs or not, even though people, quote unquote, failed the ibrutinib. And I'm doing that a lot now, actually. And what do you do? Well, the big problem is you're going to get some cytopenias. So you got to watch your cytopenias pretty closely. But I'm actually willing to live with cytopenias in people that have failed ibrutinib for disease progression, because that's typically a very bad sign. So think about that. Do it cautiously, do it carefully, and also remember that we don't really have any data doing that. But that's one approach.
So I echo the same thing. So we participated in the trial, the post-B-cell receptor failure for patients with idelalisib and ibrutinib failure. So I would echo what John just said. One thing, though, I can't overemphasize is, and I think most of the colleagues in this audience are probably well aware of this. The patients that progress on ibrutinib, actually a subcategory of them can have very explosive progression on drug. And when you take them off, it actually looks sometimes clinically like a Richter syndrome with all the B-type symptoms, even sometimes hypercalcemia, and very rapid progression of the adenopathy. And indeed, I can't overemphasize the need for biopsies in that setting, because there is a reasonable number of patients, and this will be, I think, published soon. There's a reasonable number of patients that are actually failing because they have transformed, and then it's not just simply the same old disease. In regards to the protocol, actually, this was recognized when we ran the trial, and the protocol was indeed amended to actually allow patients to stay on ibrutinib until 3 days prior to switching over on protocol. And I think what I do in clinical practice is I actually overlap by about 2 weeks. If you remember the data from venetoclax, the median time to response on venetoclax is about 2 to 3 weeks. So by the time they reach the 100 milligram dose, there is clearly evidence of response, or at least during that period, you can overlap, and then I would echo in terms of even a decision to take them off ibrutinib, I would be cautious about that.
Yes, Phyllis Klein, City of Hope Medical Group. I would like to know what is the gold standard for measuring minimal residual disease?
And you measure it off protocol or?
Well, I saw that you were using four-color flow in one situation, but I was thinking more in terms of PCR.
Well, certainly the more sensitive test would be the gold standard. It's just not something that is easily paid for in many settings and maybe necessarily widely done. But so to this point, most of our data is using just a very crude technique, which is four-color flow, or in some settings, maybe multicolor 6, 8, or 8 or 10 color flow. Even in Seattle, we have 12-color flow. What do you
They certainly do pay for PCR in monitoring chronic myelogenous leukemia.
No, I think it's reasonable. It's just in the clinical trials, it has to be built in, and that's just not the way it's largely been done.
I mean, that flow is like what you get at Quest, is that what you're saying?
Right.
Four colors, so just
Right.
confusing, okay.
That's right.
Got it.
Well, you saw most of the data is on peripheral blood.
Yeah.
Of course, that's a problem. We really want to get MRD negative in the bone marrow.
I mean, what are you measuring? What color? What do you measure?
You're just looking for the immunophenotype of the CLL cell.
Any
They say four color
So anything less, than 0.01, we would typically call MRD negative in those patients. So
you
you're
mean the CD5?
no, I guess I don't know what the four colors are. Somebody on it.
23, there's 5, 23, and 19.
Oh, I see.
5, 23, and
5,
19.
19, and then the third one, I don't remember.
So you don't measure 17p, right?
No.
No.
And no CD20? Are you measuring CD20?
As part of the flow?
Yeah.
Probably not, no, because you're then measuring all the B cell, too many.
It's always dim initially.
It is, and that's part of the reason too. So it's probably not one of the panels typically done.
And on flow, it could be false and negative because patients would have been on CD20 antibodies.
Oh, right. Oh, right.
I don't do it outside of the concept of clinical. I think I alluded to this even in my talk. I wonder, for the average patient that you're treating off protocol, what's the value of MRD negativity? Because I already, I think the data that you saw, a lot of the patients have simply disease control, very durable control. You saw the data in terms of durability of responses at 5 years, and still the median progression-free survival is not known. So for the average patient that is not going on a clinical trial, I'm not sure what would I do with this answer. Would I add agents to my ibrutinib? Not necessarily. So I'm not doing it outside of the context of the clinical trial.
Yeah, I would just echo that. I would just say, in most patients, we don't know what to do with that data. Again, that might be something that will dictate how we treat people, stopping the drug or not. We're just not there yet.
I have another question. Oh, can I?
I have.
Okay. One last question, then we move to right, and then we come back to Dr. Lindgren.
Oh,
Yeah.
Tam?
No, ask your second
okay.
question.
What is the rationale for the FDA allowing ibrutinib to be used as frontline therapy for patients without the 17p deletion? We all have many patients who get FCR or Benda, Rituxan, who are disease-free for 9, 10 years, and why would we want to even consider putting this particular patient on ibrutinib frontline without any maintenance?
It's an interesting question. We'll both comment, I'm sure, and you'll perhaps hear different things, and you might hear different things from everybody in the room. I think FCR is appropriate and reasonable as a gold standard still in patients who do not have a 17p deletion in the front line. However, and Dr. Erdath showed some of this, there are issues, of course, with chemoimmunotherapy, in particular FCR. And I think in many patients, that risk of AML or MDS is very significant over a long period of time.
We still have obinutuzumab and chlorambucil.
So I think those are also reasonable approaches. So it really comes down to a decision between patient, a doctor, what the goals are, what's right for each individual patient. And I think that's different in many different settings. So I can't tell you that every single patient in the upfront setting should get ibrutinib. I only said that for the 17p deletions. But I think that comes down to your practice style, what's best for your individual specific patient.
Thank you.
Let's get a question from right.
I have a couple of questions in regards to the use of Rituxan here. Uh, there are old studies that show that Rituxan is very useful for CLL, and it used to be used as a single agent even. Now, my questions are there studies using Rituxan with ibrutinib? Because ibrutinib is being used as a single agent. So that's one question. And a follow-up question to that is, on patients that are treated with single agent ibrutinib, and they have complete responses or close to complete responses, does it make sense to give Rituxan after that as maintenance?
Well, we'll each comment on that, I guess, perhaps. I'm not a big fan of single-agent rituximab in CLL. I think it's something that we do occasionally. Actually, in this country, we do it a lot. But it doesn't have tremendously great response rates. You could argue that obinutuzumab might be a better drug if you're looking for anti-CD20 antibodies. I think that's also controversial and debatable. But adding ibrutinib then to adding rituximab to ibrutinib is a reasonable strategy. It's not approved that way, but we certainly have data that have done that, and I would not fault somebody personally for doing that. But again, all of these things are not going to actually cure a patient. We know that. And certainly we like to get to complete remissions, but I have lots of patients who don't get quite to a complete remission who maintain a partial remission for years. So I'm not necessarily compelled to take an ibrutinib patient who hasn't quite gotten a CR and add an antibody to it to try and get them there. But it wouldn't be unreasonable if you wanted to do it. It's just not something that I would commonly do. And furthermore, the reason I wouldn't commonly do it is not just because people can do well with PRs for a long time. Remember, we're just palliating patients here. We're not curing them. The other thing, though, is that there are infectious risks with ongoing maintenance rituximab. My personal opinion, by the way, I'm getting paid for opinion today, so that's okay. That's only what it's worth. And that is to say, for me, I'm not a big fan of maintenance rituximab because over time, people will become hypogammaglobulinemic and have chronic infections. Not everybody, but many, and so I'm not a big fan of that.
All right, thank you.
Dr. Lincoln.
Yeah, so I have a couple of questions. Thank you. The first one is I just attended ASH and gleefully purchased the 710-page ASH self-assessment manual, which I'm going through diligently. And I had a 59-year-old gentleman who with CLL, asymptomatic, relative normal, CBC basically, except for a high white count, who I did a surveillance scan on, and he had developed bulky-ish disease. Again, totally asymptomatic. So I felt obligated to sit the guy down and say, maybe it's time we talk about therapy. Not terribly responsive to this idea, but he sat down and talked to me, and I said, FCR versus BR. So what I did was I went to that manual, and shockingly, listening to you today, I see you have found a survival advantage to FCR, which doesn't exist in the manual. So I pulled, while you were talking, the original study, and lo and behold, there is no survival advantage. There's a 1-year disease-free interval, survival, progression-free survival. Do you know something we don't? Could you just clarify that?
Oh, sure. So, the data I presented is what is an update from the German CLL study group. And indeed,
Thanks.
you saw the curves. There is a slight survival advantage at 3 years in favor of FCR. The ASH self-assessment book, most of the correct answers are still chlorambucil. So that reflects kind of the outdated nature of the boards. And
Got it.
But I think indeed, if the question is really, is there a survival advantage? There is indeed, at least from a randomized trial, fairly large trial, a clear survival advantage. The difference is not, it is statistically significant, but not.
To what? To what? Statistically significant.
I don't
Do
know
you remember what that
the
was?
study, I don't remember off the top of my head.
Yeah, and the reason I ask this, of course, is because I noticed that the NCCN has elevated FCR in patients under 65 to a category 1, which I thought was kind of a stretch, frankly, given the fact that there's very little difference between those two, and one doesn't blow up in your face with pancytopenias that last for 3 years. I mean, that FCR is just a miserable, set of drugs. That's.
I mean, again, so I mean that's why we do randomized trials.
Yeah.
And the trial is a robust trial, it's a large trial. The difference in terms of the percentage, I think it is around 6 or 7% difference in overall survival. And again, it's a statistically significant difference.
Okay.
And that's why when I discussed it in the slides, I left it as a VR versus FCR debate. And this is going to be an ongoing debate because I can tell you in personal practice, the last time I gave FCR was probably over 4 or 5 years ago, and that's only in the setting of a clinical trial that had FCR. I don't use it in clinical practice, but I certainly do discuss it. And I also would highlight the data relating the patients that have IGVHE mutation. There again, there may be some advantage for younger patients. Does it come at a significant cost of cytopenias, protracted cytopenias, secondary malignancies? Absolutely. But it's something that to take into account. Remember, we don't have a lot of long-term data. In contrast to FCR, we don't have, the longest patient is 6 years on ibrutinib. And even with combination, still, these patients will relapse off of therapy. In contrast to median duration of response on FCR is somewhere around 6 to 7 years. It's hard to argue with randomized data.
Yeah, it was really helpful to hear you say that you haven't used it in 5 or 6 years, because most of us haven't used it in decades.
So, okay, please.
I just want to comment on this whole thing. I agree with everything that Robert just said. But I also would say that that trial was really a German trial, right? And we know that they don't have access to all the same drugs, and they have to actually go on clinical trials to get most of those drugs. So how that played a role in survival, I think, is very important for us to figure out a long term when we look at that data.
And the second question, if you don't mind, I know I'm pressed for time here, but what do you guys do in terms of surveillance for your CLL patients? This guy that I just mentioned to you that had developed 10.5 centimeter. If you add the lymph nodes up, they were by the strictest dictionary definition bulky. I do surveillance PET scans on these people periodically. He didn't have symptoms. His LDH was not high. SED rate was not very interesting, and so on and so forth. Do you bother doing surveillance scans on these people? And I'll note that recently there was a study published on diffuse large B-cell lymphomas where suddenly surveillance scanning is bucking the trend of choose wisely, and it does appear to make a difference. Can you comment on that?
So in my clinical practice, I actually specifically do FISH analysis looking for 11q, and that specific subcategory patients notoriously will have bulky adenopathy. That's just the nature of the condition of that disease. And in that setting, I might consider, aside from clinical evaluations, occasionally doing surveillance scans. Certainly I would do it at the time of initiation of therapy, but not as a matter of routine and doing repetitive scans. With the exception of the 11q minus patients, I don't scan anyone actually.
How about
I'll just say I agree. I don't do routine scans unless I have a reason to look for something.
So a couple questions. One about routine follow-up. Do you use beta-2 microglobulin as sort of a tracking, a way to follow their disease, especially, and if you see an increase, would that get you to scan, and they're thinking about growing lymph nodes? I'm just going about that.
That's a good question. So Bill Word actually, in 2008, 2009, published a whole series of analysis, and every study that he looked at, beta-2 microglobulin had a prognostic significance. But that's kind of where it ends.
Okay.
I don't know so in a study it's kind of valuable, but do I use it as a routine way of measuring disease burden, for example, or the need for therapy?
And then one more question. Have you used ibrutinib at all with any of the newer anticoagulants? I mean, I know there's a bleeding risk by itself, but a lot of these patients have atrial fibrillation. They're already on one of these newer anticoagulants. Do you have any experience with that?
Yeah, indeed. And then I think there's actually so yes, the answer to that is yes. I've actually even used it on warfarin with close monitoring. And there is actually a published paper last year, I believe in Blood, demonstrating that it's not a contraindication. I mean, obviously now that we have perhaps alternatives available with venetoclax and some of the newer BTK inhibitors potentially down the road, we may not necessarily take the risk, but certainly then, I would watch carefully and observe the patient carefully and educate them.
Great.
But,
Thank you.
Thank you for this lively discussion. We have about 1 minute, 20 seconds left for the many cases that John...
What I'd like to do, first I want to ask one question. Since it's my meeting, I get to ask my one question. But anyway, here's a question. So when you think about sequencing, and you look about it, let's say you have a 50-year-old patient. Let's say they're unmutated or the mutated CLL. You do know there are long-term risk of the FCR, but they also have this plateau. We also know that patients who fail ibrutinib generally just have one of two mutations, you're saying, neither of which should affect the responsiveness to chemotherapy. So if you go from, okay, I'm 50 years old, now I treat them, let's say they're 8 years down the road or 9 years down the road now, maybe they're progressing on ibrutinib or whatever, is there any reason to believe that FCR would not work at that setting and then give them that, 70% 6-year or 12-year survival? What's your thoughts? I mean, what's your thoughts on that, if you going in that direction instead of, starting with the chemotherapy?
I mean, I think it's a reasonable, in other words, you're asking whether you can switch the order and...
Yeah, in other words, you say, we know that good group can do very well with FCR, but there are those long-term risks when you talk to, like, especially Richard Furman, he loves to say, he goes, you get an MDS or you get an AML on an old CLL patient, that's never a good thing. So again, if you give that patient a number of years before that risk starts, is that something, and should we be looking at that kind of question?
So just one thing, I mean, I think there's one thing that so first of all, there's no data for this. So I think I would love to have some data in terms of seeing whether this works. But having said that, it's a brilliant idea. There's one thing to take into account, which is, again, the residual burden of disease after B-cell receptor inhibitors or monoclonal antibodies. And I think there, the burden of disease is still significant. And that clone is therefore now at risk of developing additional abnormalities that could, nobody knows because we haven't, could put it at risk for transformation and significant evolution. So that's the thing that I would worry about from a intellectual standpoint. Ultimately, we would have to see in practice whether it would work.
So let me just comment to say, yes, we need to see it in practice. So that means you need to have a trial, right? You give ibrutinib, and then when you relapse, you go to FCR. I don't think you're ever going to get a patient to do that. So if you've been on ibrutinib for 5 years and you relapse and you felt great all that time and you were taking a pill every day, it's going to be pretty hard to convince a patient, no, let's do chemotherapy now when they could just go to a different oral agent.
Yeah.
It's never going to happen.
So, which is a good practice. Let's do this really quick because we got about a minute. Let's go back to our original case. And all I want to do is I just want you to answer the first questions of this first case, and then we're going to take a break. So why don't we go back to that? So remember this case. So now you've heard, we've had about an hour and a half of talking about this. But we have this patient. It's a 71-year-old, no past medical history, presents with increasing shortness of breath. So a symptomatic patient who obviously was pretty healthy starting because she was playing tennis. Comes in with anemic, thrombocytopenic, elevated white count, some mild lymphadenopathy, splenomegaly, but obviously reasons to potentially treat. Bone marrow, 100% involvement in CLL. She does have the del17p mutation, 30% of her cells. So go to the questions again. So again, after hearing the lectures too, and what you did is, do you use the del17p? Okay, so we actually, I think we went from 79% or maybe we're close to where we were. Here's a quick question for you. How do you talk to your patients about that? So you got that, you checked it, what do you say to your patient when they have del17P, Dr. Herbert?
I mean, we discuss the results in terms of, what it means. Well, I mean, this particular patient is at the time that requires therapy. But if I'm doing it as part of the initial assessment, I'll let them know. We will watch them a little bit more carefully because those patients tend to progress a little bit more rapidly to requiring therapy. And then also I would probably tell them I would completely try to avoid cytotoxics as part of their armamentarium.
Yeah, and the other thing I tell them is that when they relapse on that we're going to have to be thinking about other things, and in particular clinical trials, or actually even more aggressive therapies, such as CAR T-cell therapies or even allogeneic transplants. So it doesn't hurt in many ways for the right patient to talk about that.
Let's go to the second question. No, this was what they did before. Oh, I'm sorry, we didn't ask. No, ask it again. Well, let's actually just go to the next one and ask it again. Sorry about that. That was what we did the first time. So let's go to the next question. There we go. Now, let's do this as a new question, okay? Okay, now go to it again. Let's see, same question now. Which of the following FDA-approved regimens would you favor as initial therapy for this patient? FC or FCR, BR, tezoprenol, carnicellar, or sutumet? We've actually talked about all these, ibrutinib or idealist. See, you did convert 79 to 89, so about 10%. So that gives you 10% bonus on your. I don't know. No, we don't do that. Anyway, this was actually, I got it right a little bit 5 minutes after. We're great with time. Let's take a quick break, about 10 minutes. We'll start about quarter after. There are refreshments outside. The restrooms, I think, are just kind of right around the corner if you need them. Thank you.
It's nice seeing you, and I hope someday we can work together a little bit. So, yeah. Good luck to you on your.
So much well is that, it's funny, I went to ASH. Also, like half of this is like